present some model projects that are underway and to talk about future directions. So I'm going to be just giving a short introduction to all of our speakers today. Dr. Alexa Craig, who is a neonatal neurologist and is the director of the BBCH Scholars Academy. We have a couple of projects being presented by inaugural members, Delirium Screening Quality Improvement Project in the PICU by Janice Dudley, who is a pediatric nurse practitioner currently working in the NICU, and then a neonatal resuscitation research project in Maine Health Hospitals by Dr. ALLISON ZANNO and MISTY MELENDI from Neonatology. And then I'm going to talk a little bit about future visioning for the Academy, and hopefully we'll have time for a little bit of Q&A. So our learning objectives are to, that after listening to this grand rounds, you'll be able to describe the development of the Academy, contrast a couple of examples of scholarship that's being supported by the Academy, and learn how your project can turn into scholarship as well. Describe future plans and help you locate resources to be successful in your scholarly activities. So again, you can obtain CME. The code is 47926, and you just text it. And we have no conflicts of interest. And so I'll turn it over to Dr. Alexa Craig.
Okay, thank you, Mary. Hopefully my audio is working. Elizabeth, can you just confirm? Maybe not. Okay.
Yep, you're good.
Awesome. Okay, so thank you everybody for coming. I wanted to start by kind of asking the question, what is scholarly activity? And I wanted to ask the question from the perspective that I started as a medical student here at Maine Medical Center, and even to some extent as a peds resident, when I had no idea and not a ton of exposure. So I was kind of the guy on the right side of the screen thinking that an abstract had something to do with art. Go ahead and advance the next slide. So the truth is that scholarly activity actually consists of kind of these 4 buckets. There's research, and the research bucket can kind of break down into bench research, clinical research, big data research, qualitative, different things like that. There's the quality improvement bucket. There's educational research that can be done in advocacy work. And all of these 4 buckets, in my experience, were kind of always in like silos as I pictured them here, kind of separate and kind of a little scary and a lot confusing. What makes these things research is when someone approaches a question or a problem and they develop a clear goal for something that they want to do as they investigate this problem. They prepare diligently, they develop some kind of a method to study something. And then once they've studied it, they go through this process of sharing the results of their work, either through local or national platforms, you know, either in presentations or publications and so on and so forth. Next slide. So when I was a medical student and a resident, I kind of knew these things existed, but I had no idea whether I could possibly layer on with all the complexities of what I was already learning in pediatrics and pediatric neurology fellowship and all these different, you know, things that I was learning. How could I layer on something else? It seemed kind of unsurmountable to me until I felt neonatal neurology. And basically, you know, my chosen field is so young and so new that it was sort of impossible to embark upon studying and becoming a neonatal neurologist without simultaneously engaging in some kind of scholarly activity. And so, you know, my interest in this specific field is sort of what jumped me into wanting to learn more about all of these ways of doing scholarly output. So this was a picture taken this summer of my family and I hiking on Mount Katahdin. And what I really like about this picture, we obviously didn't get the blue sky day, is that it kind of, in a lot of ways, it kind of encapsulates what my early experience of trying to engage with a research career, what my early experience of that was like. And so in this picture, you can't really tell if I'm going uphill or downhill. It's a really precipitous drop on both sides, you know, because embarking on this kind of a career without kind of knowing what you're doing is pretty darn scary. And it's cloudy, like you can't see where you're going. And in the same way that we actually got to the top of Katahdin on this very cloudy, rainy day, this is how I've kind of approached the last 8 years of trying to learn to do research here at Maine Medical Center, kind of one step at a time, just focusing on the next 10 feet and not freaking out about what's going on either side. Next slide. So we were incredibly lucky just over a year ago, when somebody came to our medical center who has this incredible ability with a tall ladder to see above all of those clouds. And that person is Dr. Ottolini. Here's her picture. And what Dr. Ottolini has done for me in this sort of like cloudy part of research is to try to help me figure out, and lots of people around us, let the clouds part, and let's figure out how to move academic and scholarly productivity, move it forward in a more organized way within our medical center, and particularly within the Department of Pediatrics. So this more holistic approach is, instead of thinking about QI and research and education and advocacy all as these kind of silos, as I feel that they had existed before, Dr. Ottolini had this wonderful idea of creating this thing that we're calling the Barbara Bush Children's Health Scholarship Academy. It's not the Hospital Scholarship Academy, because we don't want it to live just within the hospital, and we don't want it to live just within Portland. We want it to live throughout the medical center as a whole. And so this Scholarship Academy has in mind to bring all of these silos of scholarly activity under the same roof. So the best thing, without question, that happened as a result of developing the Scholarship Academy was that we had justification for needing a children's health research navigator. And that person that we all know and love is Sarah Gabrielson, pictured here. And I love these headshots because it leaves a lot to the imagination about the rest of the person. And in my humble opinion, this is what the rest of Sarah looks like. Absolutely Wonder Woman. Her responsibilities, I mean, her email always says she works 32 hours a week. I'm certain that she in fact works 64 hours a week. And her role has been absolutely critical to the success of the Scholarship Academy by promoting all of us, by helping us with IRB applications, by organizing the monthly meetings and the educational sessions. And I could go on for the rest of my time about how wonderful Sarah Gabrielson is, but I'm gonna move on to the next slide because you guys know. One of the first things that Sarah did was she organized what we called a visioning session, which we held at Mary's house in November of 2019. We ate pizza and we drank a few beers maybe, and we came up with kind of what we thought we wanted the Scholarship Academy to look like. And I want to just read to you the vision statement. So all the people that came to this meeting were people who had some investment in moving research and academic output, moving that forward within our department. And so this is kind of the combined vision statement of all the people that were there. So what we decided was that we wanted members of the Maine Health Children's Health Service line to be professionally fulfilled because they were working together on interprofessional projects that improved patient and community health within a culture that values, supports, and promotes their academic success. And to just sort of break that apart a little bit, it's really, I think, worth highlighting, again, that it's Maine Health and not just Maine Medical Center. And that the whole point of this is to promote professional fulfillment by working together, by working interprofessionally, and then to have that happen to improve the care we deliver to our patients, and have that happen within a place where that output and that the investment that we're making is really valued and supported. And that second part is still something that we're working on within the institution. We developed 5 specific goals out of that visioning session. And some of these things we've accomplished, and some of these things are still we're working on, but we've really, I think, done a great job of developing infrastructure within the Scholarship Academy that is promoting scholarly output by the people in the Academy. We're helping our Academy members complete projects that hopefully will benefit patients and families, and may on a larger scale do that at a population level someday. Our Academy members are doing an absolutely fantastic job at the local level right now, sharing their presentations with the scholars group. and working on publications to share after that. And all of that is leading to the advancement of the academic careers of the people within the Scholars Academy. And I think the last thing is something we're all always working on. It's a subject near and dear to my heart, and that is mentorship. And so we're not only mentoring all of us residents, students, other members of the allied health professions, but we're also mentoring each other within the Scholars Activity, which has been incredibly fulfilling and fun. So after we had that visioning meeting, we nominated a steering committee. And you could argue that this steering committee was nominated, or maybe perhaps they were voluntold to join. But Dr. Anna Cairns, Dr. Weiss, Dr. Fleisch, and Dr. Youth have been absolutely invaluable supports to Sarah and Mary and myself as we've crafted together how we want the Scholars Academy to look. Next slide. Just wanted to give you kind of a quick sample of the 2020 cohort of Academy members. And what I want you to notice here on this list, which obviously is too busy of a slide, but I wanted you to see that Mary has a project, I have a project, or some of our steering committee members have projects. Some of the people doing projects have teamed up, and there's 2 of them working on a project. The participants in the Scholars Academy are nurses, nurse practitioners, physicians from primary care, physicians from specialty care. We've tried to really welcome everybody, and we really have a very wide, as you can see from the titles of the projects, a very, very wide range of methods and things that we're looking at. So it's very dynamic and very exciting. If you were to join the Scholarship Academy, what could you expect for benefits? So I think the #1 thing is a new community here of scholarship. You won't hopefully feel anymore like you're doing your research in your own little silo and you don't have any support. You would have a network of people, and then you would also have personalized support from myself and from Mary and from Sarah, help with IRB. Lots of things that used to be huge roadblocks are now much, much easier to get through. We also have monthly educational opportunities where we can try to help people fill in gaps in their knowledge and education and training. There's even small amounts of funding available. We can fund projects up to about $3,000. And most of all, it's fun. Every time that we meet as a group, I always leave these Zoom meetings feeling like I work with the best people in the world. The expectations of a scholar involve active participation in the project of their choice. And we want them to present what they're doing at a minimum of once per year to the whole group. And we want them to actively participate in coaching and membership of other members of the Academy, and then to complete some form of scholarly output, whether that's an abstract or a manuscript or a presentation. Really, it's up to the scholar what the output is, but we want them to do something and have something to show for all the input. Next slide. So I just wanted to give you a quick sample of what the monthly work in progress meetings look like. So it's always the same type of an agenda where we check in with the presenter from last month to see what they took away from the session. The meat of the meeting is the middle, 40 to 45 minutes, where the member who's presenting will present usually a 10 to 12 minute talk. And that talk has already been practiced with Sarah and I. Usually, at least I would say we've had 2 or 3 meetings sometimes to help that presenter really hone down what their questions are and give a 10-minute presentation that would be very similar to what you would do if you were presenting in a platform session in a national meeting. It doesn't have to be a finished project. It can be a project where you've gotten to a certain point and you want to know what next steps are. But it's a very, very tightly run kind of a presentation. And what we do is we invite an expert from within the Maine medical research community or QI community, somebody to support and help evaluate that presentation to give that member other things to think about. And then at the end of the session, we always celebrate if anybody's had any kind of publication or anything or grant that they've gotten, something like that, and kind of talk about what's next. And superhero Sarah got us somehow to get CME credit for doing this too, which is amazing. Next slide. This is just a real quick sampling of what the learning sessions could look like. So there's really 2 meetings every month. There's the work in progress meeting, and then there's some kind of a learning session. Sometimes the learning sessions are kind of nuts and bolts, like something super straightforward. Like on January 27th, we have a session coming up to teach people how to use EndNote. And sometimes there are other types of sessions, like you can see the word mentoring appear here several times. And so the mentoring sessions, you know, because we feel that such a strong or such an important part of what we want to do and we want to strongly support it, we have 3 sessions about mentorship. And so anybody is welcome to join those. So in the end, you know, to conclude my little section here, why would you want to apply to the BBCH Scholarship Academy? I think it's all about mentoring. Mentoring is the most rewarding, fun thing that you can possibly do. And it's not me mentoring you guys, it's all of us mentoring each other. And when you're in the Scholarship Academy, you know, in the upper left corner, we have these education sessions to help you with training. Sarah and I can, to some extent, help you define your goals and kind of get your project with some direction. And we can help you access the IRB for advice and get you experts who can coach you through more. And then the whole group together will help motivate and support you so that then we can all celebrate your successes together. And that is kind of the end of my piece. What I'd like to do now is introduce my dear friend Janice Dudley, who is going to give you a sample of what one of the projects that have been you know, ongoing. Actually, this project was started by Janice when she was doing her doctoral work at Rush University and has continued through the Scholars Academy. So Janice, I'm gonna turn my video off and hand it over to you.
Oh, thank you, Dr. Craig. And I also want to thank Dr. Ottolini too for the opportunity to briefly showcase some of the work that's being done to address pediatric delirium in our PICU. I also want to quickly put in a little plug for how the Academy has helped me transition this work very seamlessly from doctoral studies in an academic setting to then in our home organization here at Maine Medical Center. What we know is that pediatric delirium is a complication of critical illness and that it's associated with increased morbidity and mortality. What we do not know is the incidence, and that is because prior to this work, we did not have a standardized process in our unit for evaluating or treating at Maine Medical Center, and consequently, we cannot quantify the economic burden to the organization. This quality project overall has broad objectives. It's going to require several PDSA cycles, but in general, we would like pediatric delirium to be recognized and treated in all of our patients admitted to PICU level of service. And to do this, we need to make screening for delirium the standard of care for each patient, and then have this followed by a discussion and documentation on rounds each day. As a result of this process, we hope to determine the incidence of delirium in our PICU. To start off cycle 1, a process was developed in EPIC for pediatric delirium screening that included using a validated screening tool. It's the Cornell Assessment of Pediatric Delirium, or CAPD, that you can see here. And along with this, we incorporated delirium preventative measures that would be documented as part of routine nursing care. Prior to the implementation, the nurses were provided didactic instructions and were required to attend a skills fair directed at developing competency with using the screening tool. We collected data for 3 months, and after exclusion criteria was applied, there was a total of 70 unique patients that we could measure overall use of the CAPD tool. Important to note here on this slide are 2 things. First, there was nearly 96% use of the tool on every admission, but then dropped off precipitously to 50% after 24 hours. And secondly, patients who scored greater than 9 screened positive for a potential delirium diagnosis. However, you can see here that nurses documented notifying the provider only 6% of the time. So the alarming question then became, how many of these children were a misdiagnosis and therefore a missed intervention or treatment? To further investigate the decreased use of the screening, we used a validated nursing knowledge assessment test and developed a subjective questionnaire addressing barriers to implementation. We found that nurses, in fact, had an excellent fund of knowledge of pediatric delirium, as you can see here, but overall did not really see the value in the twice daily score and reporting. Our next steps have so far included a formal collaborative presentation that Dr. Gregory and I recently gave to the Barbara Bush and PICU nurses. This presentation included reviewing the screening tool and the associated developmental anchor points, addressing any knowledge gaps related to delirium. We presented some patient videos and provided some clarity around the screening process. Additionally, Dr. Gregory will continue to refine a process for addressing the delirium score on a daily basis during patient rounds, and then we'll work collaboratively with an interdisciplinary team for a standardized management algorithm. And one of the most helpful aspects of the Academy was the opportunity to present the work in progress to other Academy members and faculty, basically across silos, and receive expert feedback and suggestions. And that, for me, helped direct intervention, such as that subjective screening questionnaire on the previous slide proved to be very fruitful in determining the barriers to screening. And fortunately, I was able to collaborate with Dr. Gregory, enlist her help, and Dr. Craig's mentorship in very early stages of this work. So thank you to both of them. Also, there are other experts in the Academy who reached out to share their experience and work, particularly with pediatric delirium at other organizations. Thank you, Tom Miller. Or who had much more experience in implementation and process. So thank you, Leah Mallory and Dr. Piccarello. Next steps will include ongoing chart audits to determine if our interventions for streamlining the process and the education that we provided will increase use of the screening tool. Thanks again for this opportunity. Our next speakers are Drs. Misty Melendi and ZANNO.
Thank you so much, Janice. We wanted to take a moment to also thank Alexa and Mary for the opportunity to present today and for all the support of the Scholarship Academy. Allie and I are excited to share our Scholars Academy project, a pilot study using simulation and telesimulation for neonatal resuscitation training in rural community hospitals. Neonates undergo massive changes in cardiopulmonary physiology as they transition to the extrauterine environment immediately following birth. Approximately 10% of neonates require some assistance with breathing, while 2% require intubation. Neonatal resuscitation represents a high-risk, low-occurrence event, and a rapid, skillful response by a delivery room team is pivotal in the reduction of neonatal morbidity and mortality. The Neonatal Resuscitation Program, NRP, is a standardized method of supporting a neonate through this transition. Currently, Maine Health hospitals require all members of the delivery room team to be NRP certified. However, in small hospitals, particularly in rural areas, low delivery rates and low frequency of resuscitation make it challenging for delivery room teams to regularly practice and maintain neonatal resuscitation skills despite being NRP certified. Neonatal resuscitation training has been shown to decrease neonatal mortality. And simulation training is a widely accepted tool used to improve resuscitation skills, teamwork, confidence among medical disciplines, and is routinely used as an educational initiative. However, many barriers exist to the frequent use of simulation training in rural community hospitals, including availability of experts, simulation equipment, and the resource utilization associated with making these opportunities available across large geographic areas. While skills improve immediately following simulation training, multiple studies have also observed a decline in skills over time following those training sessions. Telesimulation using high-fidelity audio-video conferencing between the rural hospital and the tertiary care center can increase accessibility of simulation across rural states in a cost-effective manner. Maine is currently the most rural state in the United States and has 26 delivery hospitals, of which more than 2/3 deliver less than 1 neonate per day. Providers who do not regularly perform neonatal resuscitation lose confidence with this essential skill. Our previous research with Alexa Craig examined a population of infants with hypoxic ischemic encephalopathy and has demonstrated a significant outcome disparity for rural-born neonates. When we compared outcomes of term neonates born at community hospitals to those born at tertiary care centers in Maine, therapeutic hypothermia and neuroprotective intervention was initiated later, and 14% of those outborn died compared to 4% of inborns. We identified suboptimal neonatal resuscitation practices rather than delayed hypothermia as contributors to this outcome disparity, specifically delayed airway placement and excessive use of chest compressions, a foundation of neonatal resuscitation. The objective of this project is to use simulation and telesimulation to decrease complication rates and increase survival through improved neonatal resuscitation. And our lofty long-term goal is that this project will be one piece that helps to contribute to the elimination of the rural healthcare disparity for neonates born in rural hospitals in Maine. To address this urban and rural disparity, in 2018, with the support of the Women and Children's Service Line and the Hannaford Simulation Center, we developed the NICU Community Outreach Education Program, a simulation training session delivered at the community hospital site by a multidisciplinary team of neonatal experts, led by simulation-trained neonatologists and the Hannaford Simulation Center experts. In 2020, in an effort to avoid skill decline after the on-site simulation trainings, we have started implementation of a complementary follow-up program called Maine Ongoing Outreach Simulation Education, or MOOS, telesimulation after on-site trainings. These telesimulation refresher sessions bring the training team to the community hospital site virtually on a monthly basis to practice simulation skills and reassess competencies in their environment. The participants model a delivery room team with pediatricians, nurses, and respiratory therapists. The on-site community outreach program has been completed at Southern Maine, Franklin, and Waldo, with plans to complete Lincoln in May. The telesimulation pilot is ongoing at Franklin with plans for expansion to other sites. While COVID has impacted our ability to deliver the on-site program to additional sites, we have been able to launch the telesimulation program successfully.
Our on-site simulation trainings include practice skill sessions, simulation sessions with debriefing, and delivery room systems assessments. This ends up being a major commitment for the community hospital participants, as an entire multidisciplinary team must be committed for a half-day or day-long event, which includes reducing their office hours and clinic patients in order to allow everyone to be able to attend. Sessions consist of specific skills training in airway management, medication administration, emergency vascular access, and neonatal stabilization, followed by simulation sessions to assess the use of these newly developed skills in 3 scenarios: maximal airway management, moderate respiratory support, and a full code. We used high fidelity simulation mannequins, as you can see in the middle picture. They can breathe, turn blue, cry, you can hear a heart rate, and you can perform various procedures. These scenarios are performed at the community hospital in their own delivery room, as you can see in the last picture, and thus mimic the real environment. And that allows for analysis and evaluation of any systems issues that could exist. We also have quality and safety leadership that are present at all of these events. In the last picture, you can see our setup, which includes various cameras at the top of the screen, which allow us to give multiple views, including of the infant and of the entire delivery room. These cameras can then stream these different angles, so we can get a view of the entire room, a close-up of the baby and the baby's vital signs, to a separate conference room to allow the other members of the delivery room team to watch the simulation event. We subsequently invite all the participants and viewers to participate in the debriefing. This program has been very well received, but is very resource intensive and has been impacted by the COVID pandemic. This streaming technology that we use on our on-site has therefore served as the foundation for the development of our subsequent telesimulation program. Telesimulation is fairly new, but has been shown to have an excellent inter-rater reliability between on-site and remote simulation educators. In fact, recent studies in rural Canada compared on-site training and telesimulation and demonstrated comparable learning outcomes and higher procedural performance scores after telesimulation trainings. So we launched our first MOOS with Franklin Memorial Hospital. Our first event was in November 2020, and these events have continued to occur monthly. We utilize the same streaming technology that we used in the on-site. It's a Beeline software, and we stream from the rural community hospital right to Maine Medical Center. We also then overlay Zoom, as you can sort of see in the left picture, to allow non-participating viewers to watch remotely. We then use Zoom for the debriefing sessions, as you can see in the right-hand picture. In order for this program to be successful and for the longevity of this program, the Franklin Memorial's team has been extremely dedicated, and they've dedicated a multidisciplinary team of simulation champions who have received additional training on the mannequin as well as simulation in general. And all the equipment does stay at Franklin. Cameras have also been installed in their delivery rooms. Their commitment to this program has been crucial to the success. All of our simulation events are recorded and then stored on a cloud server for access at a later date. We are evaluating the success of our program and focusing on 3 areas of evaluation. 1 is provider confidence, 2 is adherence to NRP guidelines, and 3 is teamwork and communication. So to assess provider confidence, we analyze this using a Likert scaled survey with pre and post assessments after event. And then we retroactively review the recordings and analyze them using the following tools. So the first is a scoring tool for adherence to NRP. This was adapted from previously published research and analyzes both whether or not the NRP task was completed in the correct order, as well as the time it takes to complete each task. And then the following 2 tools, which are previously validated, are used to assess teamwork and communication. So the Team Steps Team Performance Observation Tool and the Mayo High Performance Teamwork Scale. All of this data is stored in a secure REDCap database for future analysis. There are many lessons that we've learned and continue to learn throughout this process. So first, the power of friends, teamwork, and buy-in is crucial. This would not have happened without the support of the Simulation Center. So Jeff Holmes, Shelly Chipman, Leah Mallory, all the sim technicians have been absolutely instrumental. Sarah Gabrielson, Anna Scott, Sam Piro have been unbelievable for project management, IRB support, REDCap, service line support, including Mary Ottolini, Xander Abbott, and Faye Weir, philanthropy support for our initial funding. Our extremely committed team from Franklin Memorial who have become sim champions, Deb Brinkman, Keelan Trask, Gabe Civiello, Emily Jacobs, and Christina Hambrick. Our IT, both here and at Franklin, who have also been super involved. And all of the above have put in a tremendous amount of effort. Never underestimate our technology problems. You need a plan A, B, and C. We have had multiple technology issues necessitating many dry runs, changes in camera location, feedback from trying to use multiple devices. And so having IT committed from both hospitals has been sort of imperative to its success. The Scholarship Academy has been amazing. They offer a great amount of help, which we were initially unaware existed. Everything from significant help with grant writing, IRB support, database creation, and also mentorship, not only from Mary, Alexa, and Sarah, but also all the other participants who have given us lots of advice and guidance. They've introduced us to additional mentors and resources for assistance. We have discovered and benefited from this expanded community of simulation experts and researchers in the field, which have broken down barriers and made us realize all that's available at Maine Medical Center and its partners to support research. Our future directions include expanding our Moose program to other hospitals. And also we have been partnering with Michael Ferguson from the PICU and Mary Ottolini and using virtual reality to try to use that as a method of simulation in our rural community hospitals. Thank you so much for your attention. And next up, we have Dr. Mary Ottolini.
So thanks to both Sarah for her amazing ability to organize the Academy as our research navigator, and Alexa as our director and chief cheerleader. And thank you to Misty and to Allie, as well as Janice, for presenting about their projects today. And so one of the things that was very attractive to me in looking at the position of the department chair here is how much already exists at Maine Medical Center, Maine Health, and the Barbara Bush Children's Hospital. And so when I was at Children's National, we kind of learned the hard way how to do this. And in 2013, we received the Academic Pediatric Association Teaching Program Award for this longitudinal faculty development program. So I just want to describe kind of the background for why we're doing what we're doing with the BBCH Scholarship Academy. So we didn't have a program analogous to MITE, like you all have here with the learning resources for faculty development. And so we started a Master Teacher Leadership Development Program, and actually started at Children's National with, it was run by the Graduate School of Education at GW, and then moved over to the medical school. And it's still in existence today, and has actually trained now probably 100 faculty at Children's National to the level of getting a master's certificate in medical education. So this academy was purely focused on clinician educators because they really were underrepresented when it came to faculty promotions. But one of the things that I found was that people who were part of the faculty development program were, even though it was a lot of work, were really excited about the year that they spent participating, similar, I think, to what people experience as a MITE scholar. But what happened then was once people finished, they just went back to their regular clinical daily grind, and really kind of felt a little bit frustrated that now they had learned these new skills, but didn't feel like they had the support or the opportunity to apply them. And so we started this academy to provide both the support, networking, and resources to try to promote faculty success in terms of academic advancement and career satisfaction. Next slide. And we had several phases of this. Initially, the planning phase, analogous to what we've done here in early on in the course of putting the Scholarship Academy together with the visioning session we had, and then initiating. And initially, we had a pretty diverse focus for what we wanted people to do who were in the academy, providing faculty development, mentoring, and really didn't focus down as much on the scholarship part until we had a consultant who came in and helped us with that. And the next, in addition to focusing on the scholarship, one of the things that I think was really transformative was the integrating part, where people within the academy started learning what each other were doing and the different strengths of their colleagues, and just began organically to start to collaborate, and then things really took off. Next slide. So we started off in 2009 to 2010, and we started with a similar number as to what we have here with the BBCH Scholarship Academy. And, you know, as you can see, the amount of scholarly output from members was really pretty low. And it actually continued to accelerate after this article was published in 2014, where I know in terms of 2017, when we did our annual report, we had, I think, 146 presentations at regional or national levels, 67 peer-reviewed publications, 28 abstracts, and 8 grants. So, and everyone who was a member of the academy got promoted. So it again turned out to be very successful. I don't think it was necessarily attributable to me, except for the fact that I tried to get good people together and tried to provide the opportunity for them to work with each other in an effective way, and also provide resources. None of these people had any additional protected time to do their research. Next slide. So I think one of the things that's really important is tracking your tracking data and helping people to see the pathway forward for their projects, and breaking it down into small doable chunks, because we're all busy clinicians. We have very busy and very important personal lives outside of medicine, and this should actually be to me, it's kind of like a work hobby. It's like it provides additional fulfillment to you in a way that the daily grind of clinical care sometimes does not. So, so Sarah's put together a tracking form to track the various stages of project development, and she meets with members as well as Dr. Craig on a regular basis to help them to move their project forward. And so the outcome measures that we're using are directly aligned with what you need to get promoted. And so we're looking at presentations, publications, awards, grants, mentorship, etc. Next. And one of the things that I learned from a mentor years ago was she told me that the most critical factor for your success, probably in other ways as well, is your colleagues. And if you have colleagues that are willing to engage with you, support you, and challenge you, you will be successful. And so one of the things that we are learning from the innovation cohort in the Innovation Center is how you can measure things that are a little non-traditional, so beyond the grants, abstracts, etc. And so we're looking at how can an academy help to enhance the networking that people within the academy are able to accomplish, because as I mentioned, those networking and collaborations are critical to success. And so this is something that Sarah is taking on as a little project to try to track this over time. And we think that we're already seeing faculty who are making connections. And again, that leads to success. Next slide. So the other thing we want to do is to track the opinions, feelings of self-confidence, experiences, barriers and motivators, and perceptions of the help that we're able to offer through the BBCH Academy for the entire department. And when I say pediatric department, to me that extends here in Portland, at MMC, subspecialties, primary care, but then also throughout Maine Health outside of Portland. Next slide. And in terms of tracking scholarship, another tool that was developed by Tom Reynolds as part of his MITE project in conjunction with Sarah is to develop a tracking tool. And this can be very effective for the faculty member, because if you're like me, I tell people do what I say, not necessarily what I do. It's like 6 months or a year goes by and you try to go back through the calendar to think about what presentations or what you've done during that time period. So using this tracking tool, we think will help people. It's very quick to keep track of your scholarly activity and all those areas that are necessary for promotion. Next slide. The other thing that's nice about it is that it's a searchable database. And so we won't have to bug you to get this information that numerous people want to learn about what you're doing, what we're doing as a department. Tufts wants to hear about this. GME wants to hear about it, the ACGME, the LCME. And so if we can get this information in one spot, you can, we're working on an output template that looks very similar to the Tufts CV, so that hopefully you won't have to enter data in multiple different areas. Next slide. The other thing in terms of resources to promote scholarship, I know Alexa mentioned the in-person, not in person these days, but the synchronous sessions that we have for works in progress, and then the educational sessions. But Sarah's also putting together this wonderful smart sheet that has resources that are available through MITE, through other resources that should be available on the scholarship website starting in February 2021. And we will have a site on it's a page through the MITE website. Next slide. So in terms of where I think I want to get your input as we move forward, because I think that the pediatric department is really is really at the forefront and when it comes to innovation, when it comes to not being afraid to pilot new projects. And one of the things that I just thinking about so many of the projects, the two that you heard about today, but then also the great work that Steve DiGiovanni is doing with looking at ACEs across Maine Health, the terrific work that Tori Rogers has done with Let's Go. These are all terrific projects, and I'd just like us to really think about how can we collect data in a meaningful way so that we can not only evaluate and show the success of the programs, but also share that with other institutions in New England and around the country, because people really need to learn from the terrific work that you're doing. So we've been chosen along with the oncology service line and the cardiology service line to be models for how to integrate scholarship with clinical priorities. And there's a 5-year BBCH strategic plan that was developed in 2018 that I discussed a couple months ago when I gave a grand rounds, but it's all the things that we are focusing on from a clinical perspective, trying to improve the health of children throughout Maine. And it also aligns with the 2021 Children's Health Service Line goals. And so we want to develop a strategic plan for scholarship that addresses what we see as our priorities for patients, for trainees, and for families. And so, you know, I see areas that would be that are very fruitful in terms of educational research and simulation. And we've had there's a small group organizing meeting to talk about simulation priorities for research going forward. Quality improvement, implementation science is very strong here. I know that Lorraine McElwain in the hospitalist division do a great job with writing up the scholarly projects that they've been working on. Implementation science, I think Alexa Craig is a role model for that with the Maine Net program that she has implemented across the state to improve neurologic outcomes for infants that experience hypoxic ischemic encephalopathy. And we have so much opportunity with population health and health services research. We have an opening for a primary care pediatrician who has training in health services research, and I think it's a tremendous opportunity. So, and then there are other areas as well, and with the new Vice President, Dr. Liz Jacobs, that we have for research, her focus is really on looking at health services research and all of these different areas of research. So, you know, we really want to encourage you all to think about, you know, is there a question that you have? Is there a project that you've been wanting to work on? And how can you use the excellent residents and medical students that also are interested in doing scholarship to move your ideas and projects forward? Next slide. So we are going to be starting to develop this strategic plan with our BBCH steering committee. And And then we're going to hold a strategic planning meeting probably in March. Hopefully, we'll have to see how things go with COVID, but we'd love to do at least a part of it in person. And there are other, since we are recognized as one of the more innovative, I think the most innovative department at MMC, I'm really going to push for getting some funding for protected time for faculty that are involved in projects that involve residents and students as a part of that, and involve some mentoring there. In my negotiations for this position, I negotiated for the research navigator, Sarah, as well as funding for faculty development. And so I've supported several people who are getting training through different programs. The Academic Pediatric Association has a program for hospitalists in teaching. It also has programs for educational scholarship, research, quality improvement. Harvard Macy has programs. If you are committed to wanting to move your career forward in an academic way, I want to support you in doing that. And also, like I said, everything that we're doing is aligned to get you promoted, to get that recognition for promotion. And I think as we become an aligned medical group, there is going to be a greater monetary reward for getting promoted, as there is at many academic institutions. So I encourage you all to think about applying to the BBCH Scholarship Academy. We want to support everyone who wants to do a scholarly project, but the Academy really is a way to do that that I think provides the most structure and opportunity to success. So we'll be sending out information. Look for it in your email to apply, and the application process will start later this month and will end March 1st. And then I'd like to open it up to questions.
So I think I was going to moderate the question session. So it looks like Dr. Reynolds asked the first question, and his question is, do people have questions about the functionality of either the tracking tool for data entry or the output database? Sarah, are we ready to use this across the whole department? Seems like Sarah ought to answer that maybe. Are you there, Sarah?
Yeah, I'm here. Can you hear me?
Yep.
Okay, great. We are very close to the functionality for the tracking tool is there entirely. Any of you can enter your scholarship activities, and they will be safe in the REDCap database and stored for your retrieval later on. In terms of the output of the searchable database, that we're still working on a few bugs. It's not affecting the data at all. It's just the way it's presented. We're also working with Dave Denton over at MMCRI Core to make a interactive dashboard. So that's what's coming for that. Thanks for the question, Tom.
And Tom just added in too that he'd be happy to discuss any of this with faculty as well if people are interested. So, that whole spreadsheet situation, there's lots more to come on that. And then another question from Dr. Olshan on the chat, I don't know if people saw it, was, are the work in progress meetings open to all? I think it would be a great way to get young investigators interested in academic pursuits. And what I answered to that was, at this point in time, we've opened the education sessions to everyone, but the works in progress meetings we had limited to just members, but that we were working as we moved forward with the next cohort to try to kind of do matchmaking with the new intern cohort to see if there were projects that were ongoing with proposals that were coming in from attendings where we could kind of blend interests together and thus improve the mentorship. For me, it's always about trying to improve the mentorship.
Yeah, and the sessions that are open to all, the educational sessions, are advertised in the Children's Health Service Line newsletter ahead of the times that they're offered. If anyone is interested in just being invited to all of the monthly sessions and you can come or not, please email me at the email on your screen, and I can add you to the list that will be receiving the calendar invites.
I don't see any other questions at this point. Does anybody have any other closing things they want to share with, any of the presenters? Hang on a second. Now it looks like Dr. Olshan has said, I wonder if one could make it that a muted admission would be allowed to those work meetings, as I think they would lead to more interest than educational sessions. Well, that's an interesting idea. I think we could, I think we should definitely consider that. And then we just had a question from Jen Jewell in the chat. Can you give examples of advocacy in the cohort? Jen, I think you should join. I am not informed or educated in any way about advocacy, and I think that that's one area of relative weakness. And I would love more support in that so that we could help people with projects. But I'm woefully not my thing yet. Anybody else have anything? Any thoughts to add? All right, well, I guess it's 1 minute before 10 o'clock, so maybe we should let everybody go. But thank you so much for attending, and we look forward to having lots of applications by March 1st. And please contact us by email if you have questions about how to apply or even want to spitball ideas before you apply.
Thanks, everyone. Have a great day.